Good morning, everybody. If folks just coming in can grab a little bit of food and take a seat, we'll get going quickly so that we can launch into the day's program. While folks are settling in, just really quickly, for folks who are new here today, who weren't here yesterday, welcome to Denver if you're from other areas. And on behalf of Community Health Partners for Sustainability, my organization, I'm Alex Lair O'Connell, the director, and of course the National Center for Health and Public Housing, our partner in this great event. Welcome, thank you for taking the time. I know that your clinics are busy, your communities are challenged, and it's tough to get away, but it's critical to get away. In that spirit, really everything we do is about partnership building, and hopefully this morning with the panel you'll hear about some potential new partners that you may or may not have considered reaching out to. Before we get into that, a couple of just quick housekeeping notes. Lost and found, if you're missing anything, it'll be up at the registration desk. We have a few items already that folks misplaced yesterday, an earring, a pair of glasses, and a very, very, very gorgeous ring. So if you're missing those things, please recover them. Today, lunch in the program, you'll note it's listed lunch network on your own. That said, there will be lunches provided in this room, so feel free, please come grab their box lunches. Please grab one. You're welcome to stay in this room for lunch and eat it, or take it and do as you will. With such a packed program, it's always critical that we give you some time to breathe, time to chat, time to socialize. But we do hope that you'll take advantage of the food. One breakout session that was listed yesterday has moved to today. So if you were looking for integrating housing and healthcare, the Stout Street Health Center, that session is now going to happen today at 4 to 5:30 in the Century Room. Again, if you weren't here yesterday, when the breakout sessions happen, other than any breakout sessions that are in this room, all of the sessions are just one flight of stairs or one elevator floor above this on the mezzanine. And finally, out in the main hallway out there, again, if you weren't here yesterday, you'll note that there are some exhibitors and vendors out there. We hope you'll take a moment during the breaks to visit them, see what they're doing, because again, in this economic climate, any resource you can get, your community is going to appreciate, and all of those are resources there for you. So housekeeping stuff finished, we can now launch into it. I'm very, very happy, again, to welcome all of you. Please reach out to the staff if you have any issues. We're all wearing green ribbons on our name tags, so anything that comes up, we're here for you. We want to make your time with us as productive and as comfortable as possible. I now have the honor of introducing our first speaker this morning, Dan Gomez, who's the Deputy Regional Administrator for the U.S. Department of Housing and Urban Development, Region 8, serving as six states: Colorado, Montana, North Dakota, South Dakota, Utah, and Wyoming. He's responsible for building and maintaining consensus among all of HUD's stakeholders to ensure delivery of services, products, and programs regarding community planning and development, fair housing and equal opportunity, federal housing and administration, single family and multifamily, public and Indian housing, and Office of Sustainable Housing and Communities, which span 48 basic housing and housing-related programs comprising $87 billion of regional HUD investments. So I hope you'll join me in welcoming Dan Gomez.
Good morning, everyone, and welcome to Denver. For those of you who are visiting our fine state, I arrived at DIA last night from a vacation at about 12:30 and got home about 1:30. So I've had about 4 hours of sleep, so I'll just bear with me if I stumble through some things. But thank you for this wonderful opportunity. I first would like to thank the National Center for Health and Public Housing and Community Health Partners for Sustainability for having HUD at the table. Usually we get put at the kids' table, and today we get to sit at the front with the grown-ups, so that's a good thing. I think it shows the ever-changing need for leveraging our partnerships, for looking at what we need to do better, and knowing that we can do things better as we move forward. I have a prepared speech, but I don't think I'm going to use it today because I know it's kind of hard to stay awake with 4 hours of sleep, and then I also know that I'm not the most inspirational speaker out there, but hope to give you some ideas of some things that are going on in our community today. As we all know, the challenges that you face with regards to public housing, and for those of you who are involved with our Section 8 Housing Choice Voucher Program, as we face sequestration and ever-dwindling budgets, we need to leverage, we need to optimize that particular avenue of partnership. And as Alex mentioned, my job is to build consensus amongst the 5 basic program offices at HUD and the 48 basic programs that we have to provide, and not including about the 100 or so boutique programs that we have. And as you all know, it's easy to get everybody to get along and move forward and have progress, and so I'll tell you how easy that is today. So as we look at some of the things that face us from a housing platform, we look at it as 3-tier. If you don't have a place to live and to start out with, it's going to be hard to be healthy. It's going to be hard to establish yourself in a community. And then it's going to be hard, better yet, to improve yourself and to move yourself out of poverty. And so from that particular perspective, it's important to have that first cornerstone of a dwelling. And so that's where HUD comes in. You ask, well, HUD doesn't know anything about healthcare centers. HUD doesn't do anything with doctors or hospitals or things of that nature. But we kind of do. If we don't have that dwelling and we don't have that platform for sustainability and just everyday life, it's going to be hard, and it's going to be impacting your health. It's going to be impacting the health of the most vulnerable populations that we serve. And we need to figure out ways to connect those things. And so one of the things that we've done here in Denver in trying to address some of these challenges and look at things that are beyond the excuses of budget sequestration or budgetary constraints is figuring out how can we make people get along. And so that's another fun thing to do for those of you who are out there, because everybody has their own agenda, which is fine. But I think that if we can find that middle ground, that compromise that allows us to progress forward, I think that you'll see some of the things that we're doing in Denver are quite novel. They are groundbreaking to a certain degree. To get federal agencies to talk to one another is a huge thing. I've been in the government for 22 years. So that means when I started, I was 22 years old, and you do the math of how old I am today. At any rate, and I never knew anyone at HHS, Health and Human Services. I never knew anyone at the Veterans Administration. I barely knew some of our stakeholders, because when you can stand up in the regional office in the ivory tower, you can essentially just administer policy and not get involved. Well, we no longer can do that. We can't be afforded that opportunity any longer to not get into the weeds, to not get out there and help you look at these solutions that have to go across the board, whether it be an application that's consistent with HIPAA as it goes through your application for public housing or your application for rental assistance. There are these many things that we have to start looking not at just the back end of things of how can we fix the outputs, but how can we fix them in the transformation stage, and how can we better yet influence the inputs of what goes into those things. And I think that one thing that this administration has done, and one thing that Secretary Donovan really wants to impress upon us, is improving our outcomes. And one of the things that we've done to improve our outcomes in Region 8 is we improved our federal collaboration. So we've done that on several fronts. And the 4 I'd like to talk today about are the National Prevention Strategy, the Olmstead Housing Coalition, the Affordable Care Act market rollout, and the, if I can read my own writing, I should have stuck with the prepared speech, with the HUD-VASH program. And so one of the things that is the theme across these is this required consensus building. This required something that I hope I don't jump ahead of Heather's presentation, but one of the things that I borrowed from the 100,000 Homes and Rapid Results folks was a methodology to do a 100-day plan to make sure that we weren't just talking heads, that you're not just listening to me today, but that you can actually complete something, that you can actually show progress, you can show measurable progress through three basic ways: through outreach, network building, and resource identification. And through each of those things, you can actually leverage what you're going to do. So from that standpoint, the National Prevention Strategy is Health and Human Services strategy to roll out the Affordable Care Act. And in so doing, there are 4 strategic directions, and there are 7 7 strategies. And right here in Colorado, we're working with 18 federal agencies to help implement the Affordable Care Act through the National Prevention Strategy. 5 of those areas that we've taken on are the active living priority, the healthy eating priority, the healthy and safe communities priority, and the mental and emotional well-being priority. And as we go through these things, we have achieved in the last 6 months more than we've done in the time as a housing entity than I've ever seen at HUD. So from the standpoint of active living, what does HUD do with active living and how do we implement that? Well, one thing that we do have, and the housing authorities know this better than I do, is that we have access to populations. We have access to those that are in the most need from a housing standpoint, that are barely hanging on in some instances, especially when you're talking about our homeless populations. And so as we look at those particular populations, our access to those particular populations through our stakeholders is paramount in educating, providing outreach, and helping everyone understand that there are resources out there, and they don't come from just one entity. They come from all of you, and they come from the federal government as well. And so as we look at those things, it's imperative that we figure out a way to reconcile them, simplify them, and get those out to those particular communities. So from the standpoint of the active living, we have an event that we've been promoting for most of this year as one of the things that we've been working on. And through our relationship with the Forest Service, yes, the Forest Service is involved in health. We are looking at putting on the National Get Outdoors Day Colorado event, which will be held Saturday, June 8th. So if you are still in town at that time, it's at Denver City Park. Goes all day. There's 4 villages. And what this will allow us to do is educate people that don't have access to outdoor activities in various ways. You can look at from the standpoint of the activity itself, or a destination from the standpoint of the forests that we have, the trails that we have to forests. We are looking at filling in gaps and identifying resources from Rocky Mountain National Park, which is in northwest Colorado, near Estes Park, all the way to Rocky Mountain Arsenal, which is out by the airport, which you all, if you're out of town, came through. So we're looking at matching up those particular access points, making sure that communities are planning accordingly, and that they're matching those resources, more importantly, to maximize them for everyone around. So that's just one thing that we've done in the active living. Another thing that we've done in the mental health and emotional well-being is that with the prevalence of all the rhetoric regarding gun legislation and the like, and how that meanders over into mental health, which you all are probably more experts are than I am, given your backgrounds, we have teamed up with the Substance Abuse Mental Health Services Administration, and they are actually training some of our staff to do mental health first aid. So this will be an opportunity to have trained staff deal with walk-ins from the general public, and also to train our stakeholders on things such as mental health first aid, which will allow us to identify what we need to do with a person with a mental illness. And so these are little things that we wouldn't have done had we not had that collaboration. From the standpoint of the Olmstead decision, I don't know if you are all familiar with that, but that's the Supreme Court decision which requires that anybody who's non-elderly disabled or elderly disabled have access to any place they want to live, for lack of a better way of saying that. And so what we've had for the last 3 years that I've been here, and there was a group that focus primarily on identifying ways that we could get more involved with implementing the Olmsted decision. We have the Olmsted Housing Coalition. That is a consortium of federal agencies, public housing authorities, nonprofits, and what we try to do there each and every time is put a better environment out there for persons that are institutionalized right now in nursing homes or in assisted living facilities, and allow them a better opportunity to go out into their own communities and choose where they want to live. And so what we've done with Colorado's Healthcare Policy and Finance Office is we've worked with them on their $26 million grant for Money Follows the Person, and it's called Colorado Choice Transitions here. And we have created partnerships with housing authorities, so much so that we have 90 vouchers specifically designated for non-elderly disabled and elderly disabled who want to leave institutionalization, and by using a housing choice voucher. And so we have 4 housing authorities, one including the State Housing Authority and your very own Denver Housing Authority, that are participating in that designation of housing assistance as being not just the bricks and mortar, but having the services go along so those persons that would like to leave those institutions have opportunities outside of that. Another exciting thing that we've been working on is the Affordable Care Act rollout, and that's the marketplace portion. So beginning in October, we will be helping identify the populations for Health and Human Services, who is the lead agency on this, to roll out the marketplaces. And we have already reached out at our National Association of Housing and Redevelopment Organizations meeting 3 weeks ago by having Marguerite Salazar, the regional director from HHS here, go and talk about this to housing authorities and understand, with the understanding that you all in public housing have access to those persons who may have never had health care insurance before in their lives. And so that's another interesting aspect of what we can focus on through these particular partnerships and maximize. And for instance, for the Get Outdoors Day in Colorado, we worked with the Denver Housing Authority, and we also marketed to every housing authority in Colorado, every HUD-assisted and every HUD-insured multifamily project in Colorado. We marketed to make sure that we can get to our goal of 15,000 participants or attendees at this Saturday's event. And this is just a way to make sure that all populations are looked at, because in HUD's assisted housing and HUD's insured housing, we touch on persons with disabilities, we touch on seniors, and we touch on families. And so I think that pretty much covers the gamut of what we can do for outreach. So it's been an interesting year and a half from the standpoint of our relationship on the ACA and also the National Prevention Strategy as we move things forward of how housing can be connected to what you all do. But if we look at it in that kind of, I don't want to say a pyramid, but as coming from the Luxor just a few days ago, is that again, looking at it from the perspective of if you have that house, then you can actually start setting that up as a platform for how you can improve your health choices, among other things, your educational choices, your economic choices, and your opportunities. That's another thing that HUD is trying to do, is make sure that our investments are wiser, that we're not contributing to concentrated poverty any longer, because it's not just a bad policy, it's wrong, it makes people sick. And so that's why one of our strategic goals is to make sure that we increase the diversity and we move things out. I don't want to take everyone's time, but the last thing that I have is the HUD-VASH program. And for those of you who don't know, that's our homeless voucher program for veterans. And one of the things that we've had an opportunity to do in this community is reach out to every level, state, federal, and local, and also nonprofits, to improve how we deliver the homeless services to veterans. And I'm proud to say that in our region, the last 100 days, we housed I think 90, is that right, Tony? 93 veterans within those 100 days. And give the Denver Housing Authority a hand for that. That's just wonderful. And also Heather and her organization for helping us see the way. For without their action plan, I don't think that most of us would have learned half the things that we did, even about ourselves, because it's always easy to point to your partner as being the one that's not letting us move forward. And I think that that's the lesson that we've learned from all these consortiums and all these partnerships that we had was that not only do we leverage, but you're going to learn more about yourself than you possibly do about those around you, because the solution is you, and the problem is not always the other person. And so I think that that's really how you have to look at these things as we move forward. And again, I thank you all for the time and for giving us a seat at the adult table this morning. Thank you.
Good morning, everyone. Thank you so much, Mr. Gomez, for that presentation. I think we have learned a lot about what HUD is doing strategically to really help residents in public housing. So what I'm going to do, you're going to hear from the next three panelists, and I'm going to just give you just a really brief description of their bios, and they will give you more information about themselves and the programs as they work with residents in public housing. So we will have next Ms. Lynnzy McIntosh, who is the Vice President at the Consortium for Older Adult Wellness in Colorado. Of course, she is trained to be a chronic disease self-management program leader. She will be followed by Ms. Kristen Pieper, who is the Policy Manager for the Colorado Community Health Network. That network represents Colorado's 18 federally qualified community health centers that are the backbone of primary care here in Colorado. And then we will have Ms. Heather Powers, who is currently the supervisor in the HUD-Veterans program that you have briefly heard about, and has worked with the Denver Medical Center for a while and very familiar with your work. So I would like to invite Ms. McIntosh to the platform. Thank you.
Good morning, everybody. I have to say, I was feeling like I had a full plate until I heard Mr. Gomez talk, and now I'm thinking I've been a slacker. So I loved what you said about consensus and about how easy it is to get everybody moving in the same direction. And I noticed that a lot of you were smiling too, because that is probably the toughest part, is to realize that we're all in this together, which doesn't mean that it's just all us. There's a lot of other people involved too. Well, my job is to work with the Consortium for Older Adult Wellness, and don't let that fool you. We work with older adults, but one of the things we have learned through our mission is that if you work with one person in the family, you are affecting the health of the entire family. And so while we may focus a little bit on older adults, we know that by working with grandmas, we're also helping moms and kids and great-grandparents and everyone around them. So first of all, I just want to say thank you. Thank you for this opportunity. Thank you, Dr. Webb. She's also a trained leader in the Chronic Disease Self-Management Program, so we are proud to call her one of our own. Also, I just want to thank you all for the work you do, not just in terms of setting policy and talking about what's possible, but in terms of really being on the ground and doing the work and making it possible for people to realize they have options and choices to make. So COA is what I want to talk about first of all, our consortium. Our mission is to connect the clinical world with community-based organizations. And we do that by training people and consulting in the areas of chronic disease self-management, in the areas of falls prevention, and in how to make all those programs work. We work with what are called evidence-based programs, meaning they've been researched and can be replicated and that they are effective. And so we train people to go back to their communities and to deliver these programs. Our programs, they get taught in a number of places. We do a lot of things in public housing. We do many programs in churches, and we're doing an increasing number of programs across the state and across the country in health centers, in the waiting room of the family physician after hours. And that is really, I think, where I get very joyful about that. Because as people get isolated, if you're one of those people who's identified as having multiple chronic conditions, your world gets a little smaller, and then a little smaller, and then a little smaller. And so you may become very isolated. You may not leave your apartment. You may not leave your community at all. You may not decide to go to church anymore. You may not be going to the grocery store anymore. But where you do still go is your healthcare provider. And so we wanted to work with healthcare providers because we wanted to be able to help the folks that were becoming isolated from their chronic conditions to have the same access to educational opportunities, self-management opportunities as everybody else did. And so it's been a joy for us to do that work. One of the other things that I work with is what we call our statewide chronic disease self-management program collaborative. How's that for? That would be what I consider herding cats. And sometimes we are all very nice pussy cats, warm, fuzzy, wonderful. And sometimes we are more like feral cats. You know, we all get a little fearful. We're all guarding our own thing, and the claws come out. But at least we're all in the same room, and we're all identifying each other as cats. So we're on the right road, yeah. But what we do with that collaborative is that we really work toward, again, building a way to do best practices and to make the programs that we do, specifically the chronic disease self-management programs out of Stanford, to make them accessible to people across the state so that everybody has access to a class that is culturally appropriate for their community, their neighborhood, their high-rise building, to get as specific as possible, but so that it's very appropriate, but it's also the same quality standards if you're having the class offered in Denver as if it's offered in Ray, Yuma, wherever. So one of the things that we really do is work on fidelity across the state. We've established a centralized referral system so that when we're working with accountable care organizations, whether we're working with the regional collaborating care organizations, whether we're working with community health centers with multiple locations, no matter what organization we're working with, there's one place that they can refer people. And then we can help them get into a class that's convenient for them and near them. So we've set up this centralized referral system. You can find it at selfmanagementcolorado.org. And we also have a standardized way of handling those referrals. We have a standardized way of reporting back to the organizations that refer to us what's happening with the people they have referred. We hear really interesting things, like even though I have COPD and an oxygen tank and walk with a cane and have multiple chronic conditions, I don't think there's anything wrong. I don't see what role I could possibly play in my own health. And we hear that again and again and again. There's a big disconnect between what we're doing and the results we're seeing in our life. Nationally, we talk about that the behaviors we have constitute 70% of what we see in our health. 30% of what's going on is our genetic factors, the walking in front of a bus factor, as I like to call it, and the genetic factors. But 70% of what's going on with our health is about what we eat, how we move, what we ingest, what we smoke, all of those things. So 70% of our health is about the choices we make. And I think that the best thing that's coming out of the Affordable Care Act is that strong connection to the importance of self-management and the support of self-management, meaning what am I able to do for myself? What small choices can I make today that will have an effect in my health on the long term? So one of the great things I've been able to work with recently is to work with the folks on a national level. There is the multiple chronic condition framework, strategic framework group that started in 2010. And what they have done is come up with, that's out of Health and Human Services, they are talking a lot about putting self-management and self-management support in context. Meaning I, as a patient, may not be able to wave a magic wand and immediately rid myself of diabetes or COPD. However, through self-management education, I may learn that if I modify certain patterns in my life, certain eating behaviors, whether I take my medications or don't take my medications, how my attitude affects my health, all of those things have a real concrete effect on my health. And it's something that can be documented, and it's something that we can look at the return on investment. So from many different standpoints, it's a win-win for all of us. So what's happening nationally is organizations like Health and Human Services with the multiple chronic condition strategic framework, isn't that a mouthful? They're talking about the importance of self-management support. The Affordable Care Act talks about self-management support. One of the groups that I've been fortunate to be a part of is the Self-Management Alliance, which brings together not only the people in government, the folks from the Center for Disease Control and Health and Human Services, and the Agency on Community Living, and the Agency on Aging, or the Administration on Aging. It not only brings those folks together, but it brings together those of us that are community-based organization, those of us who are in aging services, those of us who work with disabilities, those of us who work with public housing. All of those folks come together with the people who created these evidence-based programs. And we talk about how to make it work. How do we get this out to a lot of people? Specifically, the Chronic Disease Self-Management Program, 160,000 people since 2008 have participated in that class nationally. 160,000 people. Within Colorado, over 6,000 have taken just that one course. And what we know is that it changes the individual and helps them realize the power that they have within their own life. So if you figure 160,000 people have now seen that light bulb go on over their head and are living their life a little differently, that's very encouraging. What would be more encouraging is if there were a couple of zeros after that 160,000, because that's when we would see a real impact on all of our health and wellness as a nation. So part of, I think what is tough for me to figure out is that we talk about things from the big picture, from the visionary perspective, and I have this visual in my head of all of these great balloons, of all these opportunities of things we can do, how important it is and how important the work is, and how the Affordable Care Act is one balloon, and how the Self-Management Alliance is another balloon, and our collaborative's a balloon. And I see my job as to grab a hold of all the strings on the balloons and to try and figure out then what we do with all of them and how we move them all together and what we do from there. I wanted just to share a couple of stories with you about some of the things that we see happening out of the classes. We do this work because when we have a class, when we have participants in the class, we see the way it changes their life. We see that people realize that it isn't an either-or thing. It isn't just that I'm either healthy or I'm sick. That no matter what condition you are in, no matter what your diagnosis is, there are things you can do today that will help you feel better. And that once you are successful in one small change, once you have success at something you want to do, you can then build on that. And out of that comes great possibilities. So we have seen people that have done things like taken their A1C, their hemoglobin, who are suffering with diabetes, and have taken their A1C levels from 13.5 to 7. Which means they have taken themselves out of a very highly critical healthcare issue to something that's manageable. We've seen people lose great amounts of weight. We've seen people who have their primary diagnosis is one thing, but what they're living with on a day-to-day basis is depression around all the changes that have happened in their life. And we see them through programs like the chronic disease program. We see them be able to get out of bed, to re-engage, to have meals at congregate meal sites again, to feel like they can make decisions and they can own what's happening. So I think that it's very important to realize that no matter what's happening on the big picture with the number of people that are being affected by evidence-based programs, what it really comes down to is what we see one-on-one within the classes. And so the more that we can remember what's happening on the ground, in the meal sites, in public housing, in the community health centers, that's affecting people one at a time, the stronger we all are. So what do we do with all those strings that we're holding together? My first thought was we all need to learn to knit. And just to take all of those things and hook them together as best we can. I'm not very good at knitting, so I am going to be knotting them together until somebody can teach me to knit while they're building a big knitting machine and we all figure out how to do it. One of our staff people said, what we do at COA is that we are building airplanes while in flight. And I think that that speaks a lot to what's up with the Affordable Care Act, is we're all trying to make connections. How do we support people with multiple chronic conditions? Well, first we realize they are not their multiple chronic conditions, that they are people, and they are not, and they have options. And so, as much as I like to talk, what I try and do is listen too, to see what we can do and how we can support and help and connect. So I thank you again for letting me be here and talk about what's happening just globally in terms of the support that's coming out of Washington around self-management and around self-management support and around the opportunities for classes that can be held within your clinic, within your housing situation. There are many options that can be brought to you. So thank you for letting me share that, and thank you for being part of what we knit together. So, thanks.
Good morning. Thank you for having me. I'm very excited to be here and talk about the impact of healthcare reform on community health centers here in Colorado. So this is just a quick overview of my presentation. I'll provide some background on CCHN, on our community health centers in Colorado, and healthcare reform. I'll then talk about how healthcare reform will impact Colorado community health centers and talk more specifically about the Medicaid expansion and the exchange, and then finish up identifying some challenges and opportunities facing our community health centers as they look forward to January 1st, 2014. So the Colorado Community Health Network is the membership association of the 18 federally qualified community health centers in Colorado. Since 1982, CCHN has made strides in ensuring that Colorado's low-income residents have access to affordable, high-quality primary health care. So what does CCHN do? We educate policymakers and stakeholders about the needs of CHCs and their patients. We provide resources to ensure that CHCs are strong organizations, and we support CHCs in maintaining the highest quality care. So for those of you who aren't familiar with community health centers, there are 5 pillars of CHCs. The first is that they serve all patients regardless of their ability to pay for services. So that means that individuals and families who have health insurance, whether it be private health insurance or public health insurance coverage, as well as folks who are uninsured, can be seen and served by community health centers. The second pillar is that they're located in high-need areas. The third is that they provide comprehensive primary health care to patients. The fourth, and probably my favorite thing about community health centers, is that they are governed by community boards, and 51% of board members must be patients of the health center, which I think is very unique and special. And last but not least, CHCs operate as nonprofits or public agencies with a mission to provide health care to low-income working families. So again, here in Colorado, we have 18 health centers, and our 18 health centers provide a healthcare home to more than 600,000 of their community members. That's over 1 in 10 people in the state. And a healthcare home is a patient's usual source of primary health care to prevent sickness, manage acute and chronic illness, and reduce the need for avoidable emergency room visits and hospitalizations. Our 18 health centers operate 152 clinic sites in Colorado in 37 of our counties, but we serve and care for patients living in 59 of Colorado's 64 counties. This is a map that shows where our clinic sites are located. The dark gray counties are counties with the CHC site. The striped counties, and hopefully you can see that, are counties served by neighboring CHC, And the white counties are counties without easy access to a community health center. However, this map was last updated in August 2012, and we have since added a community health center in Summit County, which is in the middle, sort of in the middle of the state. So this will have to be updated, and it will change a bit when we do update it. So a little bit more information about our health centers in Colorado. In 2012, our health centers provided more than 2 million medical, dental, and mental health visits. And our health centers care for a third of all the Medicaid enrollees in the state, a quarter of all the Children's Health Insurance Program enrollees, and a third of all the state's low-income uninsured. So now moving into healthcare reform. So hopefully we all know that the Patient Protection and Affordable Care Act, or PPACA, was signed into law in March 2010. And it created the Health Center Trust Fund, expanded Medicaid eligibility, and established a framework for health insurance exchanges. Of course, PPACA does much more than these three things, but these are the key areas for health centers that I'll be talking about in more detail today. So the Health Center Trust Fund provided $11 billion over 5 years to expand operational capacity for CHCs to serve about 20 million new patients. And I just put a note here that because of budget reductions, some of the trust fund has been used to backfill annual appropriations for CHCs over the past couple of years. So one of the biggest ways healthcare reform will impact community health centers is by shifting our payer mix. So many currently uninsured patients will be eligible for Medicaid in 2014. In fact, CCHN estimates that the Colorado CHC Medicaid population could grow as high as 63% of total patients in 2014. And as you can see, this is our 2012 patient mix. So in 2012, we had 40% Medicaid. And again, we see that could go as high as 63% in 2014. In 2012, health centers in Colorado saw 39% uninsured, 10% private insurance, 7% Medicare, and 4% CHP Plus, which is Colorado's CHIP program. These are some other ways that healthcare reform will impact and is impacting Colorado health centers. In particular, community health centers have a special interest in contracting with exchange plans so that patients who move between Medicaid and the exchange can continue to be seen at their community health center. National data predicts that 35% of adults will switch between Medicaid and exchange in the first year. CHCs are also determining their role in supporting patient enrollment in both Medicaid and the new exchange marketplace, and they're sorting through the many ways that healthcare reform impacts their finances and staff, especially billing and outreach and enrollment staff. So the Medicaid expansion has an enormous impact on community health centers. On January 1st, 2014, all individuals under age 65 with incomes at or below 133% of the federal poverty level will be eligible for Medicaid. 133% FPL is approximately $15,282 a year for an individual and $31,322 a year for a family of 4. The Supreme Court ruling from last summer stated that the federal government cannot require states to participate in the Medicaid expansion. However, for states who choose to participate, the federal government will cover 100% of the cost of expanding through 2016. The federal match will be gradually reduced to 90% in 2020, where it will remain permanently. So in Colorado, we decided to expand Medicaid, which is very exciting. And we passed Senate Bill 13200 this past legislative session as a result. Because the Centers for Medicare and Medicaid Services allow states to offer an alternative benefit plan for the Medicaid expansion, which means that a state can offer different benefits to the expansion population than the rest of the Medicaid population, benefit design conversations are currently happening right now in Colorado between stakeholders and the state Medicaid agency, the Department of Healthcare Policy and Financing. However, our state Medicaid agency has recently indicated that they're leaning toward offering the expansion population the traditional Medicaid benefit package, at least for the first 2 years until we know the needs of this population. So that's pretty exciting. So who will be eligible for Medicaid in Colorado in 2014, and how will that impact CHCs? Well, Colorado Community Health Centers are the medical home for approximately 192,000 low-income uninsured Coloradans, 113 of which CCHN estimates will be eligible for Medicaid in 2014. The governor's office estimates that 160,000 people will be newly eligible for Medicaid, so this number does not include the number of people who are currently eligible for Medicaid but not enrolled in the program. So if you do the math, that means that CHCs are already caring for 71% of the newly eligible individuals. Another key area of healthcare reform that has a major impact on community health centers is the exchange. So healthcare reform created a framework for states to establish insurance exchanges for individuals and small businesses to purchase affordable private health insurance coverage. The exchange is a one-stop online marketplace that will allow individuals and small businesses to shop for, compare, pick, and purchase a health plan. The exchange will be the only place where individuals can see if they qualify for the federal cost-saving program based on their income to reduce the cost of premiums, copays, and deductibles. One of the functions of the exchange is that it provides access to enrollment in qualified health plans. Qualified health plans are insurance plans that are certified by the exchange, provide essential health benefits, and follow limits on cost sharing, among other requirements. Other functions of the exchange include operating at a call center and a website and providing in-person assistance through the Navigator program. So Colorado has chosen to develop a state-based exchange rather than participate in the federally facilitated exchange. A state-based exchange can use federal services, though, for certain things such as premium tax credits and cost-sharing reductions. So in 2011, we passed Senate Bill 11200, which established Colorado's exchange called Connect for Health Colorado. And open enrollment will begin October 1st, so just a few months away, and then coverage in qualified health plans will begin January 1st, 2014. One of the features of the exchange that has an impact on health centers and their patients is the new health insurance standard, the essential health benefits. The essential health benefits are the minimum set of benefits and services that must be included in health plans both inside and outside the exchange. Grandfathered large group and self-insured plans are exempt from the EHB requirement, though. So these are the 10 required essential health benefit categories. Again, that means that every plan inside and outside the exchange will, at a minimum, cover these benefits and services. The federal government has proposed a benchmark approach for the essential health benefits package as a transition for 2014 and 2015 to be reevaluated in 2016. A benchmark approach means that each state will select a plan that is equal in scope to the services covered by a typical state employer, which will then become the essential health benefits package for the state for the first 2 years. If the benchmark plan selected does not provide coverage in any of those 10 categories on the last slide, it must be supplemented. So Colorado has chosen one of our largest small group plans, it's a Kaiser Permanente plan, as our benchmark plan, and we have added the CHIP pediatric dental benefit because the Kaiser plan did not include a pediatric dental benefit. Another function of the exchange that has an impact on CHCs is to certify qualified health plans and ensure compliance. One way a qualified health plan must comply with exchange requirements is to ensure a sufficient number and geographic distribution of essential community providers, such as community health centers, to ensure access for low-income medically underserved individuals. As I mentioned earlier, CHCs have a special interest in contracting with exchange plans to ensure that patients who move between Medicaid and exchange coverage can continue to be seen at their health center. We passed House Bill 13-1266 this past legislative session, which gives the insurance commissioner the necessary authority to regulate insurers with respect to the new requirements of PPACA. One of the biggest wins for community health centers in PPACA is that our Medicaid Prospective Payment System, or PPS rate, is included and protected. Community health centers are paid differently than other healthcare providers. We're paid on a visit basis rather than on a service basis. However, a CHC may agree to a rate that is different or lower than their PPS rate as long as the mutually agreed upon rate is equal to the rate for other essential community providers. Because of all the changes happening so quickly, it looks like CHCs in Colorado will be paid on a fee-for-service basis like other providers in the exchange, at least for now, but getting our PPS rate is definitely a goal for the future. So another function of the exchange is to establish a navigator program. Colorado's exchange, Connect for Health Colorado, has created the Connect for Health Assistance Network, which combines the federally required navigator program and the optional in-person assistance program into one program. The Connect for Health Assistance Network will fund and certify assistance sites across the state to deliver local in-person education and assistance with applying for and enrolling in health insurance coverage. A majority of the Colorado community health centers have applied to be regional hubs, assistance sites, and/or health coverage guides. And funding announcements should be made soon since funding is expected to be dispersed on July 1st. So funding opportunities are important for CHCs to consider as they work to support patient enrollment, again, in Medicaid and the exchange. In May, the Department of Health and Human Services announced a very exciting supplemental funding opportunity for community health centers. This funding is meant to support health centers in raising an awareness of insurance options and providing eligibility and enrollment assistance to uninsured patients of health centers and other residents in CHC's service area. This funding is also meant to expand current outreach and enrollment assistance activities the CHCs are already engaging in, either through the Exchange's Navigator program or Medicaid and CHIP. There is a possibility of $3 million in funding for Colorado community health centers, and our health centers have submitted applications for this opportunity. So who will be newly eligible for private insurance coverage in Colorado in 2014, and how will this impact community health centers? CCHN estimates that 22,000 currently uninsured patients will gain private insurance coverage in 2014. Private insurance includes the exchange and the reformed and unreformed markets, which include markets outside of the exchange and grandfathered plans. In addition, the Colorado Health Institute, our healthcare data guru in Colorado, estimates that in 2016, 390,000 Coloradans will be uninsured statewide. More specifically, CCHN estimates that approximately 55,000 current CHC patients will be uninsured in 2014. So I think the important thing to keep in mind is that even after healthcare reform is implemented, there will be uninsured Coloradans, and community health centers will continue to care for and meet the needs of the uninsured. So this is a list of some of the challenges and opportunities Colorado CHCs are thinking about and proactively working on as we approach October 1 and January 1. I touched on most of these throughout my presentation, but I'll quickly go through them again. As I mentioned, CHCs are determining their role in supporting patient enrollment in Medicaid in the new exchange marketplace. While it is a challenge to navigate this new world of enrollment, it is also an opportunity for CHCs to assist current patients in getting coverage and potential future patients. I also discussed how CHCs are working to contract with qualified health plans in the exchange, and how being included in a qualified health plans network is a great opportunity for health centers to help ensure seamless care for Coloradans who move between Medicaid and the exchange. Understanding all of the changes currently happening and coming down the pike and communicating these changes to staff and patients is a huge challenge for community health centers. In addition, as open enrollment begins October 1st and coverage begins January 1st, it is important for health centers to be able to help patients understand their benefits and how to use them. We know that many people will be insured for the first time and will need help understanding and navigating the healthcare system. Another challenge that I think is also an opportunity for CHCs is finding ways to keep existing patients while working to attract new patients. One way CCHN is helping our CHCs do this is by marketing CHC providers as providers of choice. In addition, CHCs will be faced with the challenge of ensuring they get reimbursed for services provided. CHC staff must learn how to bill multiple new insurers. Last but not least, capacity, both provider and physical space, is a major challenge and opportunity. CHCs definitely need more providers, and CCHN is approaching this challenge and supporting the CHC workforce by growing loan repayment and scholarship programs for all levels of CHC staff, marketing CHCs as employers of choice, and collecting data to ensure CHCs are salary and benefits competitive. In addition, a majority of our CHCs are looking at opportunities to expand services, expand existing clinic space, and/or build entirely new sites. This is in response to healthcare reform, but it's also a recognition that there is unmet need now, and there will continue to be unmet need even after 2014. So thank you again.
Hello, everyone. My name is Heather Powers, and I am with the HUD-VASH program at the Denver VA Medical Center. Today, I am here to talk about an intersection, because I know there are multiple intersections between housing and healthcare. So, it's been mentioned previously, HUD-VASH, and I'm here to talk a little bit about HUD-VASH and also talk about some other broader issues within the homelessness community. But I'll start by talking about what HUD-VASH is. HUD-VASH is a collaboration between the VA, which is the Department of Veterans Affairs, and HUD, Housing and Urban Development. The VA provides intensive case management, and public housing authorities provide advocacy for the veteran, and they ensure that the veteran qualifies for the program. The HUD-VASH case manager provides a hub to access multiple services within the community and within the VA healthcare setting. Oftentimes, they are the conduit for assisting a veteran in healthcare access, housing stability, benefit acquisition, and resource connection. The HUD-VASH program began in 2008. At that time, 10,000 vouchers were awarded nationally, and at that time, the Denver metro area was awarded 175 vouchers. We worked with one housing authority, supportive housing and homeless programs, now has been a part of the Department of Housing, and we had 5 full-time employees. By 2012, the Denver Metro HUD-VASH program had grown by over 400%. At that time, we had 710 vouchers, 25 full-time employees, and 5 housing authorities that we work with. Denver Housing Authority, Adams County Housing Authority, Boulder County Housing Authority, Department of Housing, to name a few. The HUD-VASH program is recognized by the VA as a best practice for effectively addressing and reducing homelessness. In 2008, our target population was generally anyone who identified as being homeless or eminently homeless. Oftentimes, they were already connected to or participating in a healthcare system. By 2012, our target population started to change. We began to target the chronically homeless in our community. Many times, those people were street homeless, they faced multiple functional impairments, and they were not likely to be connected with healthcare within their community or within the VA system. Also at that time, the HUD-VASH program and the VA began to recognize and put forward the Housing First approach to providing healthcare and housing to veterans in our community. The Housing First approach to housing has many basic tenets, but first and foremost, it is the belief that housing is a human right. It's the practice of providing housing first and foremost, and then all additional services are provided after and are client-driven. It's not treatment or contingency-based. Tenancy continues regardless of participation in services. And services are provided for treatment follow a harm reduction versus an abstinence-based approach. Housing First is recognized by the United States Interagency Council on Homelessness as an evidence-based and best practice in the national movement to end chronic homelessness. It's supported nationally through HUD programming and partnerships locally, regionally, and federally. At its heart, Housing First claims that housing is healthcare. Housing improves a new tenant's health and social status. Housing improves their use of primary care and outpatient services. And housing reduces utilization of hospitals, jails, and emergency services. Not only is housing healthcare, housing is cost-effective healthcare. In a 2006 cost study of 200 participants, which was conducted by our very own Colorado Coalition for the Homeless, their findings were that there was a significant reduction in the use and cost of emergency services by program participants. They found that emergency room visits and costs were reduced by an average of 34.3%. Hospital inpatient visits were reduced by 66%. Detox visits were reduced by 82%. and incarceration days and costs were reduced by 76%. They also found an increase in health status among the participants. And they found that 77% of those entering the program continued to be housed in the program after 2 years. In the first U.S. controlled assessment of the effectiveness of Housing First that was published in April of 2009, they found that the program saved taxpayers more than $4 million over the first year of operation, and that during the first 6 months, even after considering the cost of administering the housing to the 95 residents within the Housing First program, they found an average cost savings of 53%. They also found that stable housing resulted in a reduction in substance use among the participants. In 2011, the United States Interagency Council on Homelessness and the Rapid Results Institute partnered with the 100,000 Homes campaign in an effort to align communities in the goal to end homelessness. This effort resulted in one of the first housing placement boot camps. It initially piloted in the greater Los Angeles area. Shortly thereafter, actually, the VA joined this movement because of the basic tenets of housing first, knowing that housing is healthcare, and knowing that housing is cost-effective healthcare. So what is a boot camp? A boot camp aligns the community around a common goal. National, state, and community leaders came together. We identified barriers and needs within the community. We created a goal in which all parties were invested in the outcome. We created a team of people from community organizations to carry out this goal. We had a specific timeline for carrying out our goal, and in this case, it is 100 days. In October of 2012, the Denver metro area participated in the boot camp. That boot camp brought together national, regional, and local leadership from the VA, public housing authorities, the local continuum of care, and other key community players such as the mayor's office and the governor's office. The expected outcomes of a boot camp are as follows: to significantly reduce processing times for the HUD-VASH voucher, to innovate around policy and process changes, to improve coordination and cooperation across agencies and local organizations, to provide better targeting and increased focus for all of our goals, and to provide a sense of shared accountability for the 100-day goals and the ultimate goal of ending veteran homelessness by 2015. I'm proud to say that over the course of our 100 days, we were able to house 80 chronically homeless veterans in 100 days. 22 of those were identified through the Vulnerability Index study, which was conducted in November of 2012. I'm also proud to say, and this is something that I really want to thank our partners for, because we were really able to come to the table and make this work for all of us. That pre-boot camp, our average time from referral to lease-up was 182. And in fact, there was evidence that pre-boot camp, some of that time was a lot longer. But post-boot camp, our referral to lease-up time was 104 days. We took that time and reduced it by 43%. We've continued our efforts forward. We're actually currently in a second phase of 100 days, and we had our 50th day last week, May 28th, 2013. And at that time, we had housed 47 chronically homeless veterans. And that was community-wide. And I want to say that our current 100-day goal actually incorporates veterans who are housed within the community, not just the HUD-VASH programs, not just the Homeless for Healthcare programs within the VA Medical Center, but through Denver's Road Home and Colorado Coalition for the Homeless and some of you may have or may have not heard of the Supportive Service for Veteran Families program. They also work to house veterans and to get them stably housed and into programming to provide wraparound services for them. So all of our programs have been able to house these veterans. I want to highlight some keys to success when you're working with your partners on these goals. Developing and maintaining partnerships through collaboration and regular meetings. It's not just enough to know that someone is out there doing something similar. It's really vitally important to these initiatives moving forward that we're in the room, that we're at the table together, that we have relationships with one another, and that we're moving forward looking at our same goals in those relationships with one another. That you identify common goals that meet the needs of the greater team and community. It helps to have mini goals within the greater goal that can be accomplished. These mini goals help to provide momentum for your teams moving forward or your community groups moving forward. When you're able to address a goal that you feel like your community needs and meet it, and then look around the table at your partners and say, yes, we did this together, and then we see the next goal and the next goal. It's very motivating. Don't be afraid to think outside the box and take risks. Oftentimes, I think we get into our own world and our own little silo of operating, and we forget that it's okay to try something different, try something new, do something that nobody's ever told you is okay to do. And then always, always remember who it is that the goal benefits. I know that there's many different people across the room today, from housing authorities and medical providers and other connection organizations and even participants in these multiple programs. I always try to remember in the HUD-VASH program that that program not only changes lives, it saves lives. And that is what I am there to do, is to provide those services to those veterans, to connect them to the services within the greater community. I wanted to take a minute to say, you may all be thinking, well, how does this apply to you? How can the boot camp apply to you? How can these principles apply to you? Many people may be here to celebrate key successes. Many people may be here to learn something new and take it back to the community or to the organization in which you work in ways to talk about things like the new plan for care in 2014, or what HUD is doing, or other smaller community organizations and what they are doing. This applies to you because in all of our missions, when you sit across the table from somebody, you may find that you're seeing two sides of the same coin, but ultimately organizing yourselves around working toward a common goal in your community, in your organization, in your greater world can be done faster, smarter, better if you're all working on it together. Thank you very much.
Wow, after that, I don't know if we can say anything further, but I would like to thank all of our guests on behalf of the National Center for Health and Public Housing and the Community Health Partners for Sustainability. We have a couple of minutes, and I think yesterday we weren't able to do this, but if we would like to end, if you have one or maybe two questions that you would like to ask from the panelists here, but they work in public housing, we'll be happy to take them. But please, let's make them very brief because we also have to complete your evaluations. So is there any question from the floor? Okay, we have, yes, we have two hands up. So we're gonna take the lady here in blue.
I'm sorry.
Do you have any literature on HUD-VASH?
On the HUD-VASH program, you know, I did put on my resource slide the website for the HUD-VASH program. I didn't bring literature with me today, but if you have a way that you would like for it to be provided for you, I'm certainly able to do that through the organizers today, if you would like that.
Great. And a question from the lady in the white? Yes, please.
Oh, I defer to Heather. She's a little bit more of an expert on that, but it's the Rapid Results
Institute.
Institute.
Yes, absolutely, and it's a not-for-profit, so they are on the internet. You can Google Rapid Results Institute and see what they have done, what they've done in communities nationwide. I don't know for sure, but they may have principles listed there that you can eyeball and check out.
And
Okay.
it's a very good resource for a few reasons. From the standpoint of the talking points that Heather had mentioned, is that it actually gives you those identifiable goals, and it allows you to do milestones, which are those mini goals that allow you to get those big goals accomplished. And again, the other thing I think is thinking outside the box, which I didn't mention before, but Heather did, is looking at innovative ways and also looking at yourself. I think that, and being an observer of this particular process, we went into it with looking at housing authorities and the different processes that they had with regards to HUD-VASH and how they got that administered. And it was kind of confusing to the VA to look at how housing authorities administered HUD-VASH. When it was all said and done, Heather and Rich de Blasio, who's the VIII 18 director for the Veterans Affairs Office here in Colorado, looked at themselves and figured out ways they could improve the process, which got to that 43%. And that's what I was talking about, is learning more about yourself than looking at your other partners out there as a result of some of these things. But the Rapid Results and the 100,000 Homes group is very good. I would recommend contacting them. And Heather, I know, has contact, and I can have a contact as well if we need to get that to you.
I know one of the housing authorities has a burning question, so we're going to take it.
This is a question actually for Kristen. You mentioned about the community health center boards, and then the majority have to be made up of people who are served. Are they elected? Are they appointed? How long is the term for? Is there training that's provided for the board members? Any comment?
That is a great question that I am not entirely sure the answer of. If I could get your contact information, I'd be happy to research that a little bit more and get you that information.
I just wanted to add, I believe this morning, I know it's in today's program, there's a breakout session specifically about board development for health centers. They're going to answer that question better than any of us can.
Perfect.
And if anyone here is an executive of a health center or a board member and wants to answer, feel free.
Oh, great.
Okay, great. And again, I want to thank Mr. Gomez, Ms. McIntosh, Ms. Pieper, and Ms. Powers for their wonderful presentations. Can we just give them a round of applause one more time? Thank you. All right.